Okay, good evening. Welcome and thank you for attending our Ahead of Cancer lecture series this evening, sponsored by the Allegheny Health Network Cancer Institute. My name is Margie Leslie and I'm a director for the Cancer Institute. There are a few housekeeping items that we'd like to cover before we start. During the presentation, all participants can type questions into the chat or the question and answer area portion of the Zoom. We will be addressing those questions at the end of the lecture if time allows. Participants are muted from being able to speak during the conference, but again, we encourage to avoid background noise, but again, we encourage feedback via the chat option. Tonight, we're excited to welcome Dr. David Bartlett and Dr. James Betler, who will be speaking about detecting cancer when curable, new technology. Dr. Bartlett is the chair of the AHN Cancer Institute, an internationally recognized cancer surgeon. He is a pioneer in abdominal cancer treatment and a dedicated, prolific researcher. He is also past president of the Society of Surgical Oncology. He serves as a senior investigator in the surgery division for the Center for Cancer Research at the National Cancer Institute, where he developed innovative surgical techniques to treat patients with abdominal and liver cancers and perform cutting-edge laboratory research in viral-based immune therapies. Dr. Bartlett received his medical degree from the University of Texas School at Houston and completed his surgical residency at the Hospital of the University of Pennsylvania in Philadelphia, Pennsylvania. He continued his training with a fellowship in surgical oncology at Memorial Sloan Kettering Cancer Center in New York City. He completed research fellowships at MD Anderson Hospital in Houston, Texas, and the Hospital of the University of Pennsylvania. He is board certified by the American Board of Surgeons. Dr. Bartlett holds membership in several professional surgical and oncology societies. He received many academic honors during his career and has been chosen as one of Pittsburgh's best doctors every year since 2006. He has published over 380 research papers in medical journals and has contributed chapters to more than 40 publications. In addition, he lectures widely at national and international meetings and conferences. James Betler, our next speaker, James Betler, is a distinguished physician specializing in radiation oncology and an associate professor at Drexel College of Medicine. He has been an active staff member at Allegheny General Hospital and other Allegheny Health Network affiliate institutions since 2009. His leadership roles include medical director for the radiation oncology at Jefferson Hospital and system director of oncology care coordination in Southern region at Allegheny Health Network Cancer Institute. He also directs the Cancer Institute's Cancer Screening and Education Program. Dr. Betler earned his Bachelor of Science in Nursing from the University of Pittsburgh in 1993. His pursuit of his medical career led him to Penn State University for a post-baccalaureate medical program, followed by his medical degree from Lake Erie College of Osteopathic Medicine in 2002. He completed his residency in internal medicine at the Western Pennsylvania Hospital and obtained board certification in internal medicine. This was followed by a residency in radiation oncology at Allegheny General Hospital, where he also served as chief resident. He is board certified by the American Board of Radiology and Radiation Oncology. His research interests are focused on innovative treatment methods in radiation oncology, with ongoing involvement as a principal investigator in several phase 3 clinical trials. In addition to his clinical and academic roles, Dr. Betler actively participates in professional organizations and committees contributing to the advancement of oncology care and education. His dedication to both patients and the training of future oncologists underscores his significant impact in the radiation oncology field. Welcome, Drs. Betler and Bartlett and Betler. I'll hand it over to you all to take it from here.
Thank you, Margie. I'll have to shorten that up for next time. So thank you, everybody, for joining us tonight. We're going to be talking about detecting cancer when curable and talk about some new innovative techniques for screening for cancer and for treatments. But hold on, I'm going to make sure. There it is. So there's a quick outline of what we're going to go over tonight. And starting off everything, when we're talking about cancer, it wouldn't be a great talk unless we talked about prevention, because that's the best thing to do other than detecting it early, which leads to better outcomes. So this gentleman here, he's on a $100 bill. Benjamin Franklin, he once said an ounce of prevention was worth a pound of cure. He was really talking about fires that were going on in Philadelphia at the time, but it applies to cancer also. How do I get this to go here? Right here? Yeah. Okay. So in prevention, the most important thing I think is trying to be a healthy weight. So a body mass index of 18.5 to 24.9 is important because obesity is linked to every cancer that we can think about. And the World Health Organization has some statistics about obesity, which are listed here, and it affects adults, children, adolescents, and even children under 5. 37 million are overweight under the age of 5. So we really have a pandemic when it comes to obesity. So physical activity. You go from having weight gain to weight loss. This is important not to be a couch potato. And it doesn't have to be vigorous activities. You could walk at a brisk walk of 3 miles an hour for half an hour a day, and that's going to do something. Cycling, household chores, gardening, swimming, dancing, things that are going to help you lose weight and not be the couch potato. Eating a better diet. Fiber is good for you. 30 grams a day will help with weight loss. Avoiding sugars. Basically, if you look at the picture up here, everything to the right is the foods that we should be indulging in versus all the snacks, the processed foods, the sugary foods, alcohol. These are all going to lead to weight gain and increase the risk for cancer. Fast foods. Apple's better than the Big Mac or the Burger King Whopper. So limiting fast foods and starchy foods, sugary foods, processed foods is going to help in reducing weight and lead to a reduction in the chance of developing cancer. Limiting red meat and processed meats, your beef jerkies, your Slim Jims. If you're going to indulge in meat, the 3 portions a day is about 300 to 500 grams of meat. Avoiding sugary drinks. Our recommendation is do not drink sugary drinks if at all possible. This is what's led to a lot of the pandemic with morbid obesity. Alcohol. If you look over here, it's involved in multiple cancers: head and neck cancers, esophageal cancer, liver, colorectal, breast. Even 1 drink a day increases the risk of breast cancer. And I like this picture here because we all know about smoking, and having a 1 bottle of wine per week is equal to smoking 5 cigarettes per week, or 10 cigarettes for women. So our recommendation is not to drink any alcohol for the best prevention. Do not smoke, chew, or vape, or if you do, stop smoking, chewing, and vaping. It's associated with lung cancer, 85%, esophageal, colorectal, bladder, basically the whole entire wheel here. A lot of people say, well, vaping helps me stop smoking. That's true, but inside the liquid for the vape, there's some chemicals that are very harmful to your body. The volatile organ compounds can cause liver, kidney, and nervous system damage. The flavorings they put in there to make it taste like cotton candy or cherry can lead to lung disease problems. And then when the liquid in the vape gets low or it heats up too much, it's known as a dry puff. It can actually produce you inhaling formaldehyde, which is what they do for preserving specimens in the lab, and that can lead to different types of cancers. Vaccinations are a way to prevent cancer. There's 2 out there that are available. One is HPV. HPV vaccine can be given to children between 11 and 12, up to age 26, and even up to 45 in some cases. And HPV is a virus that's been associated with several cancers: cervical cancer in women, genital warts, anal cancer, and head and neck cancers. We're seeing more of a rise with head and neck cancers with HPV as opposed to what we used to see in the past with smoking and drinking. Hepatitis B vaccinations, it's 2 doses in 1 month, and that can vaccinate you for preventing hepatitis B, which can lead to liver cancer. I just want to go over some statistics also. So the most common cancers and the risk of these cancers are listed here. So for women, 1 in 8 cancers, for breast, 1 in 8 women have a chance at lifetime from birth to death of developing a breast cancer. In men, the most common is prostate cancer, 1 to 8. But these are some statistics that are startling. 42 men out of 100 or 40 out of 100 women, that's about 1 out of every 2.5 individuals is going to develop a cancer in their lifetime. And here we see the estimated new cancers: prostate for men, breast cancer for women, followed by lung and colorectal. And then the deaths, lung remains at the top, and then prostate and breast. So finding cancer at an earlier stage leads to better outcomes and in many cases less interventions. So we follow recommendations for screening from the American Cancer Society, National Comprehensive Cancer Network, and the U.S. Prevention Services Task Force. And there's slight differences, but we take the ones that we feel are the most important for the patients. So we've developed a comprehensive solution for this, and it's the Allegheny Health Network Cancer Institute Cancer Screening Education Program. And every month on a Saturday, we rotate where we're doing cancer screenings at all of our Cancer Institute locations throughout our network. As far as Erie, down to Peters Township, centrally in Allegheny General Hospital, Wexford, Forbes, Jefferson. And we also, these fill very quickly. So we started a weekday clinic. Right now, it's 2 days a week. 1 day on Tuesdays at Jefferson Hospital and the other day on Wednesdays at Forbes Hospital. We plan to continue to expand that as the need prevails. We also do partnerships with other people in the community. For instance, the Pittsburgh Pirates on September 14th, we're going to be doing specific screenings for skin, prostate, colorectal, and head and neck cancer. And all of these cancers screenings events that we do, whether on a Saturday or during the weekday on Tuesday and Wednesday, there's no out-of-pocket cost to any of the patients. There's no co-pays. It's really a one-stop shop for patients to come in and get all of their screenings done at one time. And then once they're done, they're good for the year, and then next year they can come back and do this again. We do require pre-registration and appointments are required because we need to know that you're coming. So we have enough staff and manpower to do the screenings and not have you wait around. So the program started back in 2014 at Jefferson Hospital. We've found great success with it. We're finding about 20% abnormalities. So we expanded the program in 2015 into 2019 at several regional sites. And then in 2020, as everybody knows, COVID came along, and we had to put a pause on our screenings until we figured out a way to do it with COVID precautions, which we still use today. When we started back up in 2022, we saw that there was a need out there because a lot of the cancer screenings because of COVID had gone down by 80 to 90%. So we decided at that point to do one every month. And they filled up so quickly that we decided that we needed a weekly comprehensive cancer screening clinic, which my nurse practitioner, Tiffany Koss, runs on Tuesdays at Jefferson and Wednesdays at Forbes. And this is the phone number, and I'll take a pause if anybody wants to write it down to make an appointment with her. And she does all the screenings at one time, and she tries to coordinate with you having mammograms or low-dose CT scans or anything that needs to be done during the day that you come to either of these hospitals. So at our screening events, or what Tiffany does, is we have a skin cancer screening that we do for everybody. We do breast cancer screenings for women with a clinical breast exam, as well as mammography with tomosynthesis. We do head and neck exams with indirect laryngoscopies, a mirror looking at the vocal cords. We do prostate screenings with a digital rectal exam and PSA level for men. And for lung cancer, if you fit the criteria, we do a low-dose CT scan. For women, cervical cancer risk, we go and do pelvic examinations. And for colorectal screenings, we do FIT tests. Give you a card that you take home and you mail in a specimen, the stool sample, and we have it processed in our lab. Again, all of this is at no cost to you or your family members or loved ones. We also have an education component that was put on hold during COVID pandemic, and we hope to bring this back soon, where we partner with our colleagues in the community, such as American Cancer Society. We do breast model self-examination tutorials. We do smoking cessation counseling, have a nutritionist on site, And we're going to probably bring that back starting in 2022. So during the 5 years, 2014 through 2019, we had about a 19% abnormality rate, screening 6,000, a little over 6,000 patients. Most of it was skin abnormalities, but we had some prostate, breast, other things in here. And then in 2020, as I mentioned, we put it on hold because of COVID, and we saw a decline of about 80 to 90% of the screenings. JAMA Oncology published showing the trends for breast cancer, colorectal, and prostate. You see in 2020 how the dip went down on the screenings for breast, colorectal, and prostate. And what statisticians believe is that we're going to see a 1 to 2% excess in cancer mortality because of not doing these screenings over the years 2022 through 2024. And we are seeing more abnormalities since we resumed the cancer screenings because of that delay. There's a financial impact on healthcare and on patients because there's more cancer treatment that is required by not finding it at an earlier stage. And again, all this can be reversed by doing your screenings and either through our Saturday screening events or at the Comprehensive Cancer Weekday Clinic with my nurse practitioner. So when we start back up in 2021, we did 5 additional sites. We saw about a 26% abnormality. And now we're doing them, as I mentioned, a minimum 12 per year, extras with the Pirates or others. And we have our oncologists, they all come in and they volunteer their time to ensure that we have enough screening slots at each event. And it's really a quality metric for all of us to do this for you. Statistics in 2022, we had about a 23% abnormality rate and about a 19% abnormality rate in 2023. And this year, to date, we screened a little over 1,200 screenings, and we're seeing about a 20% abnormality rate this year. We still have several of the Saturday events left this year. Grove City in September, St. Vincent in October, Hempfield in November, and Jefferson Hospital in December. There's a website that you could go to, or you can Google AHN cancer screenings, and it'll take you to this website. And the phone numbers for locally for Pittsburgh or for Erie are listed here to pre-register for the Saturday events. And I'll leave that up there for a moment if anybody wants to write those down or take a picture of it. And then the weekday cancer screening clinic with my nurse practitioner, Tiffany Koss, is on Tuesdays at Jefferson and Forbes, on Wednesdays, and that's the phone number for her, which I've shown before. And next year, again, we'll have it at multiple sites, so you're more than welcome to join us there and get all your screenings done. This is where we're going to be at next year. And then I want to talk a little bit about new innovations that we have in our system and that are coming of age for cancer screening. So Vectra, this is an amazing piece of technology. So everybody knows when you go to the airport, you stand in there and then you get your x-rays done to make sure you're not carrying anything harmful to other passengers. Well, this uses similar principles. It's not x-rays, but it's photos. We're taking photos of the whole body and creating a skin map of the whole body. And it uses artificial intelligence to go and look at the lesions and determine which the most suspicious to the least suspicious. It measures it. In my mind, it's a way to have a whole body screen, and probably better than a human can do. And there's only 17 of these in our nation. And in our area, there's only one, and that's at West Penn Hospital at our, at our skin cancer center. So the whole image gets stored in the computer, and year to year when you come back, it can go and do comparisons down to millimeters on differences in growth or changes in size or suspicion of a lesion from year to year. And we also have handheld devices that are tied into the artificial intelligence, and it learns. So if we go in, it says that this is a cancer or suspicious for it, we remove it, and we go back and tell the computer it was not a cancer, it'll learn from that, from pattern recognition from these images that it takes on the body. And this is what it looks like, the handheld device where we take a picture of an individual lesion and then lesions all throughout the body. I can click on this and it'll show me exactly where it is on the body, and I can go and examine and decide if the patient needs to have further intervention with a biopsy or not. There's artificial intelligence that's coming out for breast cancer that we utilize also, that helps us recognize on mammography areas that are more suspicious for breast cancer. And these new AI tools for breast cancer screenings have increased the detection of breast cancer by at least 13%. We're seeing it with prostate cancer also. We're using AI to be able to look at a pathologic specimen from a biopsy on an individual for prostate cancer, and it helps the pathologist to find cancer that they otherwise may not have seen. So other AI tools that we're using, the Decipher Score, Artera AI, both of these are being used at AHN right now for prostate cancer. With the Decipher Score, we're looking at 22 different genes to see how aggressive this looks, this cancer. When we look under the microscope, we're looking anatomically, but this is looking for the biology of the cancer and how aggressive it can be. So when I send this off, the tissue off for sampling, it comes back with a score, either low risk, intermediate, or high. It helps me determine if a patient needs to have hormones or not based on that score and that risk stratification. Artera AI is doing the same thing with looking at a image from the anatomic view and looking at the nanometer level on different high risk features that would make that cancer more aggressive and tell us if a patient needs to benefit from hormones or not. And if we can avoid hormones in men, they would appreciate it. And then I'm going to turn the talk over to Dr. Bartlett, and he's going to talk about other liquid blood tests and other interventions that we have. And Dr. Bartlett?
Great. Well, I do appreciate everybody joining us tonight and hearing about this. And as Dr. Betler said, this is extremely important for all aspects of cancer care to detect cancer early. And all of the efforts around cancer screening, as well as cancer prevention, stopping smoking and everything, has decreased deaths from cancer since the mid-1990s. And so it is having an impact, but can have a continued impact if we continue to screen for cancer and detect cancer at an early stage. But there is a lot of technology that's developing around early detection of cancer. And that's what I wanted to kind of go into today, because, the reality is that getting a colonoscopy to screen for cancer is a challenging test, and people don't like to do it, and therefore they don't do it. It's one of those things that people can put off. If you look at scans for lung cancer in high-risk patients who are smokers, only about 5% of patients are undergoing that screening. And so 95% of the patients that should, or the people that should be getting that screening, are not getting that screening because it's a difficult test. Likewise, prostate exams and cervical pap smears, all of these are difficult tests. And so there is a big effort to come up with better ways to screen for cancers. Not to mention the fact that for a large majority of cancers, we don't even have screening tools to identify. For instance, pancreas cancer, which is one of the top killers of all of our types of cancers, we don't have a screening tool for pancreatic cancer. And so, unfortunately, the majority of cancers that we do pick up have already spread and are not curable by the time that we know they're there. So that's scary, and that's true of the majority of the types of cancers that we have. So we really have very few screening tools. So it's all about a blood test for cancer. And just to talk about it a little bit and help you understand what and why we can do this now and we couldn't do this before, it's because of new technologies in terms of us being able to, in a very sensitive way, analyze DNA that circulates in the blood and proteins that circulate in the blood that are unique to cancer patients. And basically what happens is cancers, as they begin to grow, even when they're very, very small, cells are dividing, and that's forming your cancer, but they're also dying. So they're dying and dividing and dying and dividing. And as they die, they release materials into the bloodstream, including DNA, RNA, proteins, and a variety of what we call vesicles that bud off of the tumor cells. So there's a lot of things circulating in the blood. And in the past, we didn't have the technology to really examine this or identify this, but now we do through very sensitive genomic sequencing assays and through PCR that you're all familiar with. These are very sensitive ways that we can identify DNA circulating in the blood and other things circulating in the blood. And this gives us hope that we can, in fact, begin to identify a blood test for cancer. And just to give you an idea of where we are at this time compared to where we're going to be in another 5 years, right now we have a number of tests that are already in the market as blood tests to screen for cancers. And I just show a few here. The Cancer-Seq identifies 16 different cancers. Pan-Seer, 5 cancers. This Burning Rock ELSA sequencing test, 12 different cancers. And the one that's most commonly utilized and well known is the Grail test, which identifies greater than 50 different cancers. And it uses a fancy way to identify DNA circulating in the blood that's specific for cancer, and the fingerprint of how that DNA is arranged and what we call methylated identifies what type of cancer they're looking at. So not only can they say, hey, there's cancer there, but they can tell you what type of cancer. Now, as you might imagine, nothing is quite as good as we would like it to be, but this is what I would consider the first step. And, in another 5 years, we're going to be light years ahead of where we are now. But even the first step is pretty good. And so right now, if you look at early stage cancers with this blood test, we can pick up 17% of the stage 1 cancers with this Grail test. And that doesn't sound great. We would like to pick up 100%. But if you're talking about, for instance, pancreatic cancer, picking up 16.8% at a curative stage of pancreatic cancers, when we have absolutely no other screening modalities, this can be a game changer. And likewise, stage 2, it's 44%, stage 3, 77%, stage 4, 90%. So as we get to a higher stage, we can pick up more of these cancers with this blood test. And in this original study, of all the people that did not have cancer or knew they had cancer that were tested, 1.4% had a positive test. So a little over 1 in 100 people who got the blood test had a positive test. And if they had a negative test and they followed these patients, 99.1% of them were actually cancer-free, so they did not have cancer. But of the ones that tested positive, 38% were found to have a cancer. And so you can see that in a population of patients that otherwise may not have been screened at all, they were able to pick up a number of cancers. And some of these patients, there are a lot of stories out there of patients who had the test and, found cancers that they didn't know they had, and then were able to have those cancers removed and cured. So, there is hope in this, but I have to admit that it's not where we want to be. And right now, the cost of this test is expensive. It's $949, and it is not reimbursed by insurance companies. So it is an out-of-pocket expense. And this just gets to whether it makes sense financially to have this test performed. It's not going to be right for everybody. If this were a free test, I think it would be right for everybody. But as a very expensive test that's not perfect in terms of sensitivity and specificity, it may not be right for you. But this is something that we discuss at the screening clinics that Dr. Betler talked about with the patients, and kind of give them in more detail the pros and the cons of these tests. But I think I'm bringing it up more as an example of the future here. Screening blood tests for cancer will be in our future, and we will get better and better with these tests. And this is just, like I said, just the initial toe in the water, so to speak. Now, there's a lot of things that a blood test for cancer can do. And this is another exciting test that's currently on the market and is very commonly now utilized for cancer patients. And this is the SignaTest assay. And what this does is it identifies in the blood tumor cells that are circulating and identifies the DNA in those circulating tumor cells, or cell-free DNA that's just floating around that's related to cancer cells. So you can see, and it sequences the DNA and identifies the DNA that's specific for the cancer in a single patient's body. So every patient is analyzed to see what mutations exist in their specific tumor. And then those mutations are tracked using a PCR technique. And again, we all know what PCR is because we've watched some murder show. What's the common one? I can't think of it.
LA Law.
LA, whatever. So we all know what PCR is, and it's a very sensitive way to look at DNA. And so once we identify what mutations are specific to your tumor, then we can track those mutations in the blood and see whether that cancer is growing, whether it's going away, whether it's there at all. And we can track the cancer during treatment and after treatment. So, and these are a couple of different types of cancers that were studied. And these are survival curves where if everybody is cured, they're up here at 1.0. And as patients die of their cancer, they fall off on this curve down to 0. And what you see here is that if after surgery and chemotherapy, the ctDNA or the SignaTest test is negative, it predicts almost everybody is cured of their lung cancer in this situation, versus those that are still positive, and these are the ones that go on to recur. Likewise, in colon cancer, if it's negative, most patients are cured. If it's positive, they're not. In bladder cancer here, you can see it. In breast cancer, the same. So it's a very good test to identify whether or not there's any tumor left in the body. And as you can imagine, for these patients that are going to recur and that we can predict they're going to recur because they're positive, these patients need additional treatment, more frequent scans. We need to, be on top of their cancer so that it doesn't overwhelm them. So again, a very good test, and this will only get better. So a blood test that identifies what's happening to your cancer as you're being treated and as you kind of follow through your cancer journey. Now, here's what we're doing at the Allegheny Health Network, which is, being a big partner and a unique partner in research to identify a blood test for cancer. We've developed what we call the AHN Moonshop Program, which was to take all patients coming into our system, and we have somewhere between 8,000 and 10,000 new cancer patients that are coming in annually to Allegheny Health Network. And to take all of those patients at all of the sites, we have 23 different sites across Western Pennsylvania, all of these sites, and offer them enrollment in this clinical study. And the clinical study simply allows us to draw blood on a monthly basis during their cancer journey. And what we're doing with that blood is we process it for this cell-free DNA. And what that cell-free DNA is the tumor DNA that's being shed from the tumor into the bloodstream. So we process it so we can identify that. And we can, with that DNA, we can just simply measure the concentration, how much tumor DNA is circulating in the blood. And we've been able to identify that just measuring the concentration of cell-free DNA, we can predict how well a patient will do with their cancer treatment. Those with a lot of cell-free DNA circulating in the blood are going to do a little worse than those with minimal cell-free DNA circulating in the blood. So that's been an exciting advance that we've identified in our patients. And we are also showing that we can identify all the mutations within their tumor by identifying the mutations in the blood, and we don't have to biopsy the tumor. We can simply identify those mutations in the blood and avoid biopsying the tumor. So that's what we've currently identified. We now have over 6,000 unique patients that have enrolled in this study. We've had over 17,000 blood draws and over 113,000 plasma tubes, blood tubes now in storage from all of our sites across Western Pennsylvania. And as you might imagine, this is just an enormous resource for us to share with other technologies that are being studied, as well as develop our own technologies. And it's, in my mind, just a matter of time for us to continue to improve the techniques to identify the cancer patients and be able to move forward with a blood test for cancer. And I just show you this example, but this was a study that we helped with from a company called Delphi. And what they've been able to do is identify that they look at all of the DNA in the blood, and they look at the length of fragments. And I guess that's more complicated than we really need to get into, but it's kind of a fingerprint type approach to the DNA in the blood. So it's not looking at the specific mutations, it's just saying overall, when we look at the DNA, what's the length of the DNA fragments? And you can see that in a patient that doesn't have any lung cancer, it's very narrow. In those with benign lung nodules, it's very narrow, but when you have cancer, it becomes this very scattered looking graph where these fragments are very long. And so what that does is differentiates the patients without cancer with patients with cancer. And so, like I said before, only 5% of eligible patients get screened for lung cancer. With a blood test, we're hoping to get that into the 90th percentile range. And so in combination with Highmark, we are beginning a study where patients at high risk will be offered a blood test instead of a CT scan. And with that blood test, if it's positive, then they will move on to a CT scan to confirm that positivity. But if it's negative, they will just go on to a blood test again in a year. And so what we're looking at over time is to see if this really does impact our ability to screen for lung cancer and ultimately pick up additional lung cancers at early stages that are treatable. So just an exciting spin-off of our Moonshop program, and another example of where we're advancing screening for cancer using a blood test. And this is another one that just got reported, and you may have heard it recently, just in the last few weeks, because it just was approved by the FDA as another blood screen tool for colon cancer. And there have been others that have been also FDA approved, or at least one other test, but this represents a significant advance over the prior blood test. And what the studies showed is that with this blood test, which again examines specific aspects of DNA circulating in the blood in patients with colon cancer, it can pick up 80 cancers 83% of the time. So the majority of time, if you have a cancer and you get this blood test, it's going to be positive. And so, this is a potential screening tool for patients who refuse to get a colonoscopy. Unfortunately, tests like this, and again, this is just the first toe in the water. We're going to be much better in another decade. But right now, it only picks up 13% of precancerous polyps. And that's where colonoscopy has the benefit, because colonoscopy not only identifies cancer, but also prevents cancers. Because in a colonoscopy, you can find a polyp and remove it before it becomes cancer. And so that's why colonoscopy is still the better test than a blood test. However, for those patients, again, who refuse to get colonoscopy or just know they're never going to schedule that colonoscopy, then get a blood test. And at least it's better than nothing. And 83% of the time, it's going to pick up cancers if they're there. Again, the major problem with this is the cost, $900 for the test, not covered by insurance at this time. And so again, it's going to be on a per patient basis as to whether it's worth that cost, or colonoscopy is still a free test because they are covered by insurance and there's no copays associated with it as an approved screening test. So colonoscopy is still going to be the preferred method. But it gives you an example of we are moving forward with these blood tests. They are becoming commercially available and even FDA approved now for testing. And so we're excited about it. And this is just what we're hoping to achieve in the future, because we're talking about cancer and cancer screening. And there are so many barriers to cancer screening. Not only the ease of the test, not only whether a test exists, because one doesn't exist for pancreas cancer, like I said, the ease of the test, because Pap smear versus a blood test, is a no-brainer. We're always going to prefer a blood test. So those are barriers. But the other barrier is simply access. And, patients having to come into a doctor's office to be screened. It's just not high on their list. And, it's hard enough when you have a problem to get to the doctor, let alone to prevent a problem. And so our goal, and something we've talked about and looked into and are continuing to find ways to fund, is to get a mobile screening center. And these do exist in the nation, none here in Pittsburgh, but this would be a way to bring screening to the populations that are at highest risk and have the most trouble with access. And in a one-stop shop, in a van where we could get CT scans, we could do blood draws, we can do pelvic exams, breast exams, mammography, all in a single mobile unit. This, to me, would also break down an important barrier, which is just access to these screening modalities. And I am going to invite Dr. Betler to comment on this, because he's been thinking about this and dreaming about this, I would say, for a long time.
Yeah, as Dr. Bartlett said, there is a large barrier for people getting access to the doctor's office. Also, there's access problems with copays, which is why our cancer screening programs, when you come there, you get all your screenings at one time, no copays. So for that one trip to doctor's office, rather than one to a gynecologist, one to a dermatologist, one to a GI doctor, it's all in a nice little package. But a mobile unit like this that has basically a tractor trailer full of screening modalities allows us to pull up to shopping centers, churches, Hinesfield, I'm going to always call it Hinesfield, to do mammograms during the month of October when we have Breast Awareness Month. We can go to a regatta or to the arts festival. We can partner with industries and go and have health fairs for the employees, and they don't have to take off. There's a astonishing number. I think it's 54,000 people we have data on that have not had a single screening that they're eligible for from Highmark data over the past year. And those people, it's not that they don't want to have the screening, it's the access. It's taking off work and going there and burning a vacation day to get your screenings done, which is why the Saturday events help with that. Or if you're off on a Tuesday or Wednesday, helps there. But this would allow us to pull up to an industry that has a health fair, do all the screenings that we need to do, and not have to have people take off work to go and do a screening. It's basically making hospitals again, which is important for the patients and for their prevention.
I think, you've heard a lot about screening. It is important for us as a blended entity. If you think about it, it's the best way to cure cancer. It's the best way to avoid all of the challenging aspects of cancer care when it's metastatic and late, and all of the negative aspects of treatment and side effects and so forth. And it also reduces the cost of care. And so it's in the best interest of insurance companies and in the government to really solve this problem of screening, because picking it up early increases cure rate, decreases cost of care, decreases the impact on quality of life for patients. And it's just that win-win-win for everybody involved. So extremely important and major priority at AHN for the Cancer Institute here. So again, I do thank you all for joining us, and we would like to open it for questions. Anything is fair. I'll let you, Margie, if you want to read any questions. It looks like we might have one, but please join in if you have questions for us.
Sure. There were several other questions that I had chatted answers to along the way. So there were lots of other questions which I believe I had the answers to. So I put those in there. But this one question just came in, and the question is, when you are showing a blood test is effective and obviously less expensive than a procedure like a colonoscopy, why does an insurance company not cover it? I mean,
yeah, it's a great question. And, part of that, for instance, the Highmark CED program and the study I talked about for lung cancer screening was, and that CED program is called Coverage Evidence Determination, I think. So it's a way that the insurance companies can look at these products and decide whether it does, in fact, help patients. So when something comes on the market like this, it's being pushed very hard by the commercial companies, but it still has to be proven that in a population of screening patients, that it does in fact save lives and improve care. And so, for instance, in the Grail test, where you only have a 13% sensitivity rate in stage 1 cancers, those early cancers, if you're testing a huge population of patients, at the end of the day, are you spending more time chasing false positives, in other words, positive tests that turned out not to be cancer, and creating a lot of anxiety in patients, or are you actually saving lives? And so all I'm saying is these tests are so early on that they need to be studied better before commercial vendors, commercial insurance payers, as well as government, CMS, Medicare, decide to cover these as tests. So we think it will get there. It's just going to take a little while.
Yeah, as Dr. Bartlett had said in his talk, which was a great talk, we're just now starting to put our toe into the water. The new Shield test that just came out, FDA approved, it got FDA approval before the CMS, who does the billing codes, had time to even make a comment on it. It actually came from a New England Journal of Medicine study that was published in March, and then October or by August, it's approved. But if you remember his slide, there's only 13% of those precancerous polyps that are being found. And specifically, I think the question that Margie had asked, why not just do these blood tests rather than colonoscopy? The colonoscopy is still finding those polyps, removing them when they're a precancerous state before they're invasive, and leading to basically no further treatments once you remove it in many cases. So the home run there is that sure, it's a prep, it's invasive, but when you find something to truly prevent cancer, removing these polyps rather than detecting a cancer that's already there with the shield, which is 83% detection, but only finding those precancerous lesions 13% of the time. That's why it's just not there yet, and we still are just dipping our toe in the water. But I agree, it'll be there in within the next decade. We're going to see probably a blood test for many of these cancers. In the Grail test that we had talked about, all the stages combined, stage 1 through stage 4, early stage to more advanced stage, the sensitivity for that is 51.5%, which means just over half the people that have a positive test are truly going to have a cancer. And there's a lot of anxiety getting a positive test if it's not accurate enough yet, but it's going to get there.
Okay. A couple other questions. We have a few more minutes. We can still take a few more questions. If you are post-treatment for anal cancer and pre-cert PET cancer, would the blood test be favorable to monitor future recurrence if you're post-cancer diagnosis? So if you're into survivorship, I believe this question is trying to articulate, and you've had anal cancer in the past, what would the blood test be appropriate for surveillance of?
Yeah, so the best test for surveillance is the SignaTest assay, and the way they do that is they have to have access to the original tumor in order to identify the mutations that existed in that tumor, and then they can follow the blood to see whether those mutations are showing up in the blood. So the SignaTest assay is the one for patients in surveillance.
Okay. One other question is, and I missed this tool. How do you get access? And they're saying to the MIA tool for breast cancer. I'm not familiar with that.
So the MIA tool is an add-on, an artificial intelligence that's added on to the mammography that helps identify areas when the mammographer, the radiologist who does readings for mammograms, when he's looking at the images, this is a computer-aided tool that helps them identify those areas that they may have otherwise missed in about 13% of the time.
And
Okay, so it's not something patients get access to, then the mammographer has access to it to report out.
Yeah, it's an adjunct for the radiologist to make him be able to identify breast cancers better because we're all human, and this helps to make us superhuman.
Great. Any additional questions? I've cleared the question queue. If there are no additional questions, we'll pause a minute here to see. Oh, here's one. There's when might we see governmental approval? I guess when might there be approval for some of these items that we've talked about? I guess that are not yet covered by insurance, but that's hard to say.
Well, the approval. First, I don't have that crystal ball, but I think it's coming. These companies all are working with government officials to get their products to market and get a reimbursement code for it. And we're actually working with them through with Highmark for those CEDs that we talked about, studies to see how we can best utilize it. When you have a test like Grail, where there's a 51.5% sensitivity, that's all comers. But we're starting to find in some circles that if you have risk factors, and there's a study showing that if you have morbid obesity, which we talked about as a risk factor, smoking, and HPV, those people who have any one of those, that sensitivity rate goes up. So we may end up seeing these come to market even but not for everybody, but to be associated with risk factors to help identify these cancers sooner at an earlier rate. If we went and tried to use the Grail test, which is over $900, on everybody over 50 years old, I read an article that it would be over $500 million, and that's only a snapshot in time for 1 year. You're going to do that again in a year, that would bankrupt probably all of the health system and take away the healthcare dollars for other things, heart disease. So what has to happen is we have to find better ways of using them until the sensitivity improves on its own, and we get better at identifying these cell-free DNA that are floating in the blood. And also the industry needs to come to the table with us and lower the price point to make it more affordable for everybody.
Okay, thank you. Last question that I'll read here is, how do you know, or how does the patient know if the MIA tool is being utilized by the person that reads the mammogram? I'm not sure if that's specified anywhere in the report.
Usually they aren't. Sometimes you'll see in a report that there's a CAD, a computer-aided device, is what they call it, because they're not going to use the true name and give promotion for one company over another. But usually they'll have on there a CAD, like a computer-aided device in the mammogram report if you're reading it. And plain mammography and mammography with tomosynthesis is a three-dimensional view, which has also improved the ability to detect earlier cancers or breast cancers earlier with better detection rates than traditional mammography alone. And we have tomosynthesis at all of our mammography units in our system.
Okay, great. All right, thank you for that presentation. We finished the questions. I'm going to proceed with some closing remarks. Thank you all for attending our Ahead of Cancer lecture this evening. Please continue to join us monthly for our Ahead of Cancer lecture series as we focus on continued work with cancer screening, early detection, treatment, and survivorship. As a reminder, tonight's lecture was recorded. If you're interested in rewatching tonight's lecture, check back on the AHN YouTube channel at www.youtube.com/Allegheny Health Network for the full recording in about a week. This video, as well as other past lectures, will be posted under the Ahead of Cancer playlist. If you'd like to schedule an appointment or have questions regarding a potential cancer concern, please call the Hope line at 412-578-4673 to schedule your appointment. Thank you for that great presentation, Drs. Bartlett and Betler, and thank you to all those who attended this evening. Have a very nice evening. Thank you for attending.